Welcome to this video on antimetabolite chemotherapy, where we will provide a comprehensive overview of its mechanisms, pharmacokinetics, pharmacodynamics, adverse effects, and toxicity. Antimetabolites are cytotoxic drugs that mimic normal metabolites, primarily in nucleotide and folate metabolism. They inhibit DNA and RNA synthesis, targeting rapidly dividing cells like cancer cells. These drugs are cornerstones for various cancers and are also used as immunosuppressants. Antimetabolites are classified into four main groups: folate antagonists like Methotrexate, Pyrimidine analogs such as 5-fluorouracil and Cytarabine, Purine analogs and thiopurines like 6-mercaptopurine, and ribonucleotide reductase inhibitors like hydroxyurea. A key characteristic is cell cycle specificity. Antimetabolites primarily target the S phase, where maximal cytotoxicity occurs during DNA synthesis. This also results in toxicity to normal rapidly dividing tissues like bone marrow and the GI epithelium. Methotrexate, a folate antagonist, works by inhibiting dihydrofolate reductase. This blocks the reduction of folic acid to tetrahydrofolate, depleting thymidylate and purine nucleotide pools necessary for DNA synthesis. Methotrexate pharmacokinetics are dose-dependent and nonlinear. It has saturable intestinal absorption and poor CNS penetration at standard doses. Primary elimination is via renal excretion. Drug interactions with NSAIDs and PPIs can increase its toxicity. Methotrexate is used in oncology for various cancers and in autoimmune conditions. Major adverse effects include dose-limiting myelosuppression, hepatotoxicity, nephrotoxicity, and pulmonary toxicity. Leucovorin rescue is crucial for high-dose therapy. 5-fluorouracil, a pyrimidine analog, is converted to active metabolites that inhibit thymidylate synthase, deplete thymidine, and are misincorporated into DNA and RNA. This leads to S-phase arrest and apoptosis. 5-FU is administered intravenously and has a rapid distribution and short half-life. It is extensively metabolized by DPD. DPD deficiency can lead to severe toxicity. Bolus injections cause greater myelosuppression, while prolonged infusions cause more mucocutaneous and GI toxicity. Cytarabine, another pyrimidine analog, is phosphorylated to Ara-CTP, which inhibits DNA polymerase. It is highly S-phase specific and key for acute myeloid leukemia. Pharmacokinetics show rapid deamination to an inactive form, and renal excretion necessitates dose reduction in renal impairment. 5-FU is used for colorectal, gastric, and other cancers, as well as topically. Its toxicities include myelosuppression, hand-foot syndrome, cardiotoxicity, and neurotoxicity, especially with high doses or renal dysfunction. Cytarabine toxicities are dose-dependent, including myelosuppression and GI toxicity. High-dose specific toxicities include cerebellar neurotoxicity, conjunctivitis, and the Ara-C syndrome, which presents with fever and rash. Gemcitabine, a defluorinated deoxycytidine analog, has active diphosphate and triphosphate forms. It inhibits ribonucleotide reductase and causes masked chain termination in DNA. It is used for pancreatic, NSCLC, and bladder cancer. Toxicities include myelosuppression and pulmonary toxicity. 6-mercaptopurine is converted to active thioinosine and thioguanine nucleotides, inhibiting purine synthesis and incorporating into DNA and RNA. Azathioprine is a prodrug non-enzymatically converted to 6-megapixel, sharing the same metabolites. 6-megapixel and azathioprine have variable oral absorption and hepatic metabolism. Pharmacogenomics are critical due to TPMT polymorphisms. Low TPMT leads to severe myelosuppression, while high TPMT can cause hepatotoxicity. Concomitant use of allopurinol requires dose reduction to prevent life-threatening toxicity. Toxicity of 6-megapixel and azathioprine is diverse. Dose-limiting toxicity is bone marrow suppression. Hepatotoxicity can range from transaminase elevations to rare hepatic necrosis. Other toxicities include GI upset and long-term risks, like opportunistic infections and secondary malignancies. Other purine analogs include fludarabine, cladribine, and pentostatin. Fludarabine inhibits DNA polymerase, ribonucleotide reductase, and DNA primase. It is used for CLL and indolent lymphomas. Fludarabine toxicities include profound lymphopenia, myelosuppression, neurotoxicity, and autoimmunity. Cladribine and pentostatin are similar, targeting lymphoid cells and having overlapping toxicity, notably immunosuppression and bone marrow suppression. Hydroxyurea inhibits ribonucleotide reductase, blocking the conversion of ribonucleotides to deoxyribonucleotides, which depletes DNA precursors and halts DNA synthesis in the S phase. Hydroxyurea is used for chronic myelogenous leukemia, myeloproliferative neoplasms, and sickle cell disease. Dose-limiting toxicity is myelosuppression. Other toxicities include GI upset, mucocutaneous changes, and a long-term risk of secondary malignancies. Key class-wide pharmacodynamic themes include being most active in rapidly dividing cells, interfering with nucleotide synthesis, and inducing cytotoxicity via DNA damage and apoptosis. They require intracellular activation and have schedule-dependent effects. Important drug interactions exist, such as folate supplementation modifying methotrexate toxicity. Xanthine oxidase inhibitors potentiate thiopurine toxicity, and renal impairment increases exposure to many antimetabolites. Adverse effects target proliferating cells. Common effects include bone marrow suppression, leading to neutropenia and anemia, and GI mucosal injury causing stomatitis and diarrhea. Organ-specific toxicities include hepatotoxicity from MTX and thiopurines, nephrotoxicity from high-dose MTX, neurotoxicity from high-dose Ara-C, and cardiotoxicity from 5-FU. Alopecia is also a class-typical adverse effect.